Joining us on TheInformer, one of the frontline staff from the Royal Melbourne Hospital, Dr. Kudzai Kanhutu. Doctor, welcome to TheInformer.
Thank you.
Can we talk about
Pleased
this
to be here.
pandemic that has taken an enormous toll around the globe? When you first heard as a medical professional that there was a coronavirus and it was starting to make an impact in Europe especially, what were your first thoughts?
Look, early on, I'll admit to have been a little bit, obviously, an infectious diseases physician. You're curious, you're interested. We'd had Zika a couple of years ago. We'd had, SARS outbreak previously. So initially, that feeling of, okay, so there's another organism that's been newly identified. Let's see how this goes. More curiosity rather than panic. So just trying to understand what is it, what's it related to, and trying to get this the basic medical facts about it. But I can admit to have been at that window period or that honeymoon period a little bit, potentially even you could call it blasé, in the sense that we'll deal with it, we'll see what it is, and then we'll find ways to manage it, and it will be able to be somehow contained.
So when did it
Um,
change?
I would say certainly there's a real penny drop moment when we had our first case at the hospital. So that Australia Day weekend was when we had the first patient in the hospital, and then you think, okay, so it's arrived now, because up until that it's theoretical. Until you've actually had a patient in your hospital or in your area, it's theoretical at that point. And the reality is, even with the really terrible new infections we've had, emerging infections like Ebola, you'd be hard pressed to find a single person in Australia who's actually dealt with or treated a patient with Ebola. So there was still a little bit of that suspended animation feel about it.
Yeah.
Well, it's not kind of here yet. And then all of a sudden, yeah, we have a patient in our hospital who has coronavirus. We've swabbed them. And then by the end of the weekend, we've now sequenced it. We've now been able to culture it or grow it in a lab. And that was sort of a world first, obviously outside of China. So that honeymoon period lasted probably a little bit after that, because then it's like, oh, we've only had one. You try to minimize or contain your
Yep.
own,
Yep.
inclination towards any catastrophizing. And then it really became apparent that we were looking at something unprecedented when you're starting to get sort of text messages or WhatsApp messages from people or colleagues overseas, or informal email chains or trails that are coming through from people who are, 2 or 3 weeks ahead of where we were at that point. And then you suddenly think, wow, okay, these are people who are normally very, the medical community tends to be very,
Matter of fact.
hysteria is not we're very matter of fact. We deal with the facts. Okay,
Yeah.
so what are the facts? What's the pathophysiology? What
Yeah.
are we going to do? It's okay. It affects this group of patients, and we'll be looking for this type of patient when they come in. And then all of a sudden it became, oh, at Lombardi, one of the professors has become infected. 20% of their workforce is infected. They can't staff the wards anymore.
Wow.
They've got patient staff in ICU now. And then you think, whew, if we even had a quarter of this happening here, it's unmanageable.
Wow. Now, you said you got your first patient came in on that Australia Day weekend. How did they present?
So it was a fairly classical presentation. So what we'd sort of been told to watch out for: recently returned traveller, fever. And it's been written up. It was written up as a journal paper at the time, describing, the way that this particular individual had presented. So quite classical. So it was in people's minds to test for it when they
Sure.
arrived. It
Sure.
wasn't a case of one of these more atypical presentations that we've had as time has gone on. So it was about as textbook, and thankfully as textbook as you could get, in the sense that everybody was thinking, okay, we've got to test for this new thing, because this is exactly the prototype of person we've been told to watch out for.
So what's happened now over the last few weeks? What are you seeing in the front line?
What we're seeing at the front line is that flip from, this is something that happens in quarantine hotels. This is something that happens on cruise ships. This is something that happens in known clusters where we know exactly what's going on, to this is something that is happening everywhere and we can't see it, and we can no longer keep tabs on it, because there are people out there, some of whom are symptom-free or have mild symptoms who may be transmitting. So what's really changed is that feeling of how do you actually meaningfully contain this is now the moment to say, look, we just have to commit to stage 4 and the implications that has for people. We've done masks now, and at the beginning, masks were, the evidence at that stage was, there are some settings where you'd recommend it, but, we'll hold off, or we're concerned that people will go out and bulk buy masks, then we won't have any in the hospital. So do we really want to be telling people to use them when the evidence isn't there that everybody should be using them? Will they use them well? To now we've shifted so far, we've drifted and shifted so far from where we started, where it was, only let us know if you've got symptoms. We will only test you if you've got symptoms, to if you even think you have, the messaging went from, do you have these 5, 6 symptoms, to, do you think you've got coronavirus? If you think you've got it, go and get tested, which is very nebulous as a concept to tell someone, do you think you've got it? Head out and go and get tested.
Well, do you think it was helpful that the government chose to put their testing sites in near the supermarkets?
Look, I think you have to find that balance from a public health perspective of, if you want to encourage people to get tested, and we know compliance, for want of a better word, with health advice is questionable at best. If it was great, we wouldn't have the obesity epidemic we have. Everybody would be non-smoking and they'd be exercising their 30 minutes a day. We know that it's hard to get people to comply. So it was trying to find that balance of, how do we position this testing so that it's not an inconvenience and people just go, oh, I'm on the way to the shops, let me just go and get tested. But that's not to say that in that moment of being tested, the advice of what do you do next should not be really explicit. Is that if you are symptom free, so at the time we thought if people are symptom free, they're going to be in that rung of patient who is less likely to be shedding and spreading, you super spreader type person, because they're not coughing, they're not sneezing, they're not sort of dripping with snot. So you can reasonably say to that person, look, thank you for getting tested. You didn't actually have any symptoms, but we swabbed you and we'll let you know, go about your business. But if you've come to the testing station, you are already feeling a bit 50-50, you've got a little bit of a sniffle, that is the person that you tell, it doesn't matter how long this test result takes to come back, you need to go home and wait until you get this result, as opposed to the person who's done it, out of curiosity. But in terms of their relative risk of being a transmitter, it's less, because they're not coughing, they're not sneezing, they're not, they don't have a fever of 40, and you're really worried that, this person is just, a hot super spreader.
Now, early on in their messaging, we heard that it was a real problem for people with compromised immune systems, especially for the older people, and for the young and the children, not a problem at all. Have you found things different?
Look,
the experience is different to the story?
The experience is different now, because I think people's chronological age is very different from their physiological age. And what I mean by that is that, as much as we know that when people get to the real extremes of age, and I mean extreme in the medical sense, 60, 70, 80 and beyond, there's definitely a jump off point where if you get sick and you're over the age of 60, you are far more likely to die. But people these days, you can line up 40-year-olds, and you'll see there's a very big difference between someone who's in good health and 40 years old and somebody who's really not in great health and 40 years old. And it's not always visible either that, this is the person who is, having early signs of kidney problems, for example, early signs of diabetes. You can't tell. So it is a real truism to say that although there is a general trend, there is nobody who should feel like they are immune, or even if they have an infection and they're 25, that's not to say you're not going to be that person who had 5 days of really bad illness, got over it, and then found themselves completely washed out, or had a mild headache, or a headache that really interfered with their ability to work for the next month. That's not a good outcome either. So this thing that, if you're really young, you're just going to have maybe a few days of bad cold and then you're back to 100%. What we found is that there is a long-term sequelae or other things that continue to happen to you, and they differ from person to person, and it's not age specific.